Good evening, members, good evening, officers, and good evening to the public. Welcome to the Health and Adult Social Care Overview and Scrutiny Committee, 18th of January 2021. Can I ask our Democratic Services Officer, Joe Tyler, to read out the housekeeping notices, please?
Thank you, Chair, and good evening to everyone present and watching the meeting live online. Please note that this meeting of the Health and Adult Social Care Overview and Scrutiny Committee on the 18th of January 2021 is being recorded by the Council invited to by. Always turn on your video function when invited to speak, and if you could do this a few seconds before you do speak, it will allow the stream to run more clearly. Please state your name before you speak if you have not been introduced already. Please remember to mute your microphone when you are not speaking. On the items before you this evening, after the committee has heard from officers or presenters on a specific item, the chairman will ask committee members who wish to speak to do so by using the raise hand feature in the bar at the top of your Teams window. The messaging bar should not be used unless you are raising a point of order or providing the wording for an amendment. If at any point you would like to speak again, please use the raise hand feature again. And please remember to lower your hand once you have spoken. Finally, please ensure background noise is kept to a minimum and that mobile phones and other devices are turned off or switched to silent for the duration of the meeting. Thank you, Chair.
Thank you, Joe. To save on time, I shall be reading out the committee members that are present. So there's myself, Councillor Jackie Edwards as Chair, Councillor LJ Evans, who's Vice Chair of this committee, Councillor Cheryl Johnson, Councillor Diana Butler, Councillor Kieran Wilson, Councillor Sandra Moore, who is substituting for Councillor Chris Matthews, Councillor Mark Robson, Councillor Roberto Rocca, Councillor Susan Phillips, Councillor Andy Jones, Councillor Dwayne Farr, and Louise Bates, who is the Health Watch Dorset manager, who is also a member of this committee. We have others joining us tonight. We have the two portfolio holders with health. We've got Councillor Karen Rampton, portfolio holder for adults, and Councillor Nicola Green, portfolio holder for COVID resilience, public health and education. Several other members have been invited. I'm not sure whether they're here. Perhaps they will be if they are going to speak. And Councillor Mark Howell, member champion for wellbeing, and Councillor Lawrence Fear, member champion for mental health, were invited, along with the chair and the vice chair of Children's Overview and Scrutiny Committee, Councillor Richard Burton, and vice chair Councillor Lisa Lewis were also invited. Officers we have at this meeting are Jan Thorgood, Corporate Director for Adult Social Care, David Vitti, Director of Adult Social Care Services, Sam Crow, Director of Public Health Dorset, Elaine Stratman, Principal Officer Planning and Quality Assurance, Donald, Principal Officer for Joint Commissioning Learning Disability, Sophia Callahan, Deputy Director of Public Health at Public Health Dorset, Elaine Hurl, Principal Programme Lead for Mental Health at Dorset CCG, Sally Sandcraft, Director of Primary and Community Care NHS Dorset CCG, Elaine Redding, Corporate Director for Children's Services, Penny Davis, Interim Head of Quality Assurance, and Joe Tyler is our Democratic Services and Overview and Scrutiny Officer tonight. If anyone has been missed, I'll ask them to raise their hand and introduce themselves. Nope. I'll now move on to the agenda items for this meeting.
Sorry, Chair, just to say someone's raised their hand. We've got a couple of officers also in attendance.
Okay, would they like to? I can see, is that Phil Vitti? Phil Hornsby, I can see.
Yeah, Phil Hornsby, Director for Adult Social Care Commissioning for the Council.
Okay, sorry to miss you off, Phil.
problem.
Have we got anybody else?
Yes, Chair. Hi, good evening, everybody. You've got me. I'm Betty Butlin, Head of Long-Term Conditions and Adult Social Care.
Okay. Welcome, Betty. Thank you. I'll now move on to the agenda items. Oh, sorry. I see another hand. Helen Percy.
Hi, I'm Helen Percy. I work for Dorset Healthcare on Home First, and I'm here with Betty to give the later agenda quick update on Home First.
Okay, thank you very much. No more hands. I'll now move on to the agenda items. Apologies. Joe, have we got any apologies for this meeting?
We do, Chair. Thank you. As you mentioned earlier, we have received apologies from Councillor Chris Matthews for this meeting, and subsequently item 2 substitute members, we have Councillor Sandra Moore attending in place of Councillor Chris Matthews. Thank you very much.
Thank you. Agenda item 3, any declarations of interest? If you have any declarations of interest, can you please indicate by using the raised hand? Councillor LJ Evans.
Thank you, Chair. For transparency, I declare that I am a bank employee of the University Hospice Trust.
Thank you. And Councillor Cheryl Johnson.
Thank you, Chair. Again, for transparency, I'm a staff nurse at Royal.
Okay, thank you very much. Agenda item 4, confirmation of the minutes. Unless anyone indicates otherwise, I assume the committee agrees to confirm the minutes of the meeting held on the 30th of November 2020 as an accurate record.
Agreed.
Okay, thank you. Agenda item 5, unless anyone indicates.
Chair, sorry, Chair, Joe Tyler here. I think we have a couple of hands up for the item 4 on the minutes.
Okay, sorry, yeah.
Okay.
I can see Councillor LJ Evans. Have you got a query on the minutes?
I think Councillor Butler may have been before.
Councillor Butler.
Thank you. Yeah, it wasn't actually a correction. It was just a question as to whether we can include all those who attend our meeting to be listed. I know other committee meetings do include that. Can we have them also in attendance? Thank you.
Chairman, I'm happy to note that comment and take that away for next time.
Yes, that's fine. Yes.
Thank you.
Anybody else? Councillor Evans, is that a?
So just a couple of very minor corrections on the minutes. Thank you, Chair.
Thank you.
I've emailed these into Joe already, but I think it's page 9, just to correct the spelling of Accurex, and page 10, we just wanted to clarify with Louise Bate if it was a young officer who'd been appointed or perhaps a youth officer. That's on page 10.
It's a youth officer.
It is a youth officer, not
Thank
just a
you.
very young one. Fabulous. That was all. Thank you very much.
Thank you, Louise. And anybody else? Anything else? Nope. Can we move up? So the confirmation of the minutes, is that everybody agreed now? Yeah, thank you. Agenda item 5, the actions sheet. Unless anyone indicates, I assume the committee agrees to note the action sheet, which tracks the decisions, actions and outcomes arising from previous committee meetings. Have we got anybody? Are we happy with? Okay, so moving on to agenda item 6. Any public issues? Have any public issues been received for this meeting?
No, Chair. We have received no questions, comments or petitions for this meeting, so there are no public issues. Thank you.
Okay, thank you, Joe. Agenda item 7, the portfolio holder update. Can I call upon portfolio holder Councillor Karen Rampton and Nicola Green to provide their updates to inform the committee of issues or actions have arisen since the last meeting. Councillor Rampton, would you like to go first?
Yes, thank you, Chair. Thank you very much, and thank you for your invitation to speak at the committee meeting. I will be brief because you've got a big agenda and you'll probably talk far too much. I just want to briefly start by saying that I was very pleased to be invited to the first champions meeting the other day, and quite a few of the champions sit under the health agenda, and it was really interesting and really good news to hear how briefed everybody was and how they knew exactly what they wanted to do within the constraints, of course, of the position that we're in because of the pandemic. And I was very keen to say at the meeting, let's be really careful not to put too much pressure on any officer until the champions roles are clarified. And I understand that's something that our monitoring officer is doing at present. So it is going to be a role that will be fulfilled by those champions with probably little support at the moment, and I think that's absolutely right. But I was very impressed by those champions, and if can I just name them actually? So we've got Julie Bagwell, who's disabilities, Diana Butler, learning disabilities and community projects. I think Mark Howell, who wasn't at the meeting, is wellbeing. You yourself, Chair, a dementia champion. Lawrence Fear, mental health, and Dave Kelsey was also present. He's armed forces, a kind of a bit of a cross-cutting health role there as well. The other bit I wanted to touch on was the budget. I'm not going to go into masses amount of detail. We had a monitoring report at the last council meeting on the 5th of January. But I just wanted to kind of restate that the main pressures are currently a support kit of over £5 million. That includes the increases of the care costs because we're having to place residents in homes which are a higher cost than the government funding. And of course, there's an added pressure in that around half of our homes are currently on suspension due to COVID, which means that no placements can be made in those homes until the care home is tested clear. And of course, we've got staff, care home staff, who are isolating or testing positive. I want to reassure committee that this government has funded the care sector in BCP by 11.5 million by way of the infection control grant, and this is to pay for the PPE, to help homes pay staff if they have to self-isolate, and to help restrict the movement of the staff between care homes. And this funding has been distributed to the independent sector, as well as our in-house services, and of course our own social care company, Tricuro. And as you would have read in the council papers on the 5th, most of the £4.2 million of mitigating savings on the budget are on course to be delivered. However, this pandemic has absorbed all available staffing resource, so some savings inevitably won't be delivered. There is an impact from the Scheme 1 hospital discharge scheme funding being phased out. And because we're struggling to carry out eligibility and financial assessments from the Scheme 1, from Scheme 1. So the real impact on the budget will not be clear at this moment until we can get round to carrying out those assessments. And the council commissions care, of course, for the whole of the health and social care system, and that includes self-funders or those people who are eligible for continuing health care. So all of those people do need to be reassessed, and particularly the continuing healthcare clients. We just don't know how much of those costs at present will be staying with the council and how much will be picked up elsewhere by health colleagues, or of course by people who fund their own care. We're having to buy in interim beds at the moment. This will be and is financially significant. We've put £1.3 million in the MTFP, but we're expecting those costs to be much higher than that. We do have emergency funding, COVID funding for next year, it's likely that we will have to dip into that money to pay for this. But I wanted to finish there, Chair, unless there are any questions. And I just wanted to say thank you so much to the officers who are just doing such a sterling job. The negotiations and discussions with our colleagues in health, those people doing the hospital discharges. Everybody is literally on their knees, and I really want to pay tribute to our officers in the health and social care system and thank them for all the work that they're doing. So I'll finish there, Chair, unless there are any questions for me. Thank you.
Thank you, Councillor Rampton. And yes, I think the whole committee would like to thank the officers for all the work they're doing. Has anybody got any questions for Councillor Rampton? No. Can we move on then to Councillor Nicola Green for your report, please?
Thank you, Chairman, and good evening, members, good evening, officers, and thank you for the invitation to your panel this evening and the opportunity to speak. As you'll be aware, my portfolio touches many of the other services within the council. The directly health and public health related aspects of it we'll look at through the next agenda item, Chairman, so I won't really go into any detail on that. But I do think it's worth just observing that during this current lockdown, where many are working from home, I'm working from home, and lots of our staff are, there are, as Councillor Rampton has touched on, there are a number of staff, a large number of people across the public sector, but particularly council staff, who are working their socks off, is the only way to put it, to continue to deliver the public services which are needed as much today as they are on any other day, be it in housing, in homelessness services. And I am conscious that once you start writing a list, you run the risk of omitting anyone. So if I do, the error is mine, and please don't think that there is any value attached to that. But we have people in our bereavement services working hard to support families in tremendously difficult times. There are registrars still working, babies are still being born, children still need access to schooling and to schooling away from school, which was words that we didn't think we'd be using a year on. We are still collecting refuge and recycling, and plus delivering that day job during across the wealth of adult social care and public health. And that, of course, is backed up by an enormous corporate effort, and we shouldn't forget the great job that officers in revenues and benefits are doing to back everything up and to make sure that our businesses and our residents are receiving the grants that are available. And then, of course, we have that huge job, and there is a team hard at work to communicate all those messages to as many of our residents and businesses in the very best way that they can. So everybody is leaning into the wheel, and it is a huge collective effort. Chairman, I'd be very happy to take any questions, but I am conscious that something that this board perhaps isn't cited on, and you might want to consider for your work programme, is something specific to what's going on in public health more generally, or I could send out a brief, a short briefing note to your members if that would be, if that's the way in which you'd like to approach it. Clearly, we know that some services across the board have been stood up and stood down through this period. But if you would like me to come back perhaps next time specifically on public health, I'd be very happy to do that.
Thank you, Councillor Green. I think, yes, there are things that are still going on. People are still trying to quit smoking, lose weight, etc. So I think that would be very useful. I'm not sure how the other members feel, but I'm sure they'd be in agreement there. And perhaps, yes, if you wanted to just send a quick report across, that would be very good. Thank you. Councillor LJ Evans, do you have a question?
Yes, thank you, Chair. Obviously, food is important to vulnerable families during this COVID crisis. This is something that's received a lot of media attention recently. I just wondered if you could comment on how BCP is supporting our vulnerable residents at this time, please.
Chairman, with your permission.
Yes.
Sorry, I'll just assume it then. Yes, thank you, Councillor Evans, and thank you for the opportunity. And I will do my very best to be brief because I could talk for a lot longer on this. Essentially, it breaks down, if you like, into two groups. So there has been a lot of publicity, national publicity, recently regarding children who are eligible for free school meals. And prior to Christmas, the council worked very closely with schools to set up and funded by national government to set up a voucher offer over the Christmas holidays. Since the notional return to school, you'll be aware that that's changed back to a food offer, which is run from schools, bearing in mind schools are directly funded for that provision, and that's been ongoing. Clearly, if there are any changes to national guidelines, we will look to step up to that and to make any changes that are necessary. There is, however, a much wider offer to our communities, and I'm very glad that you raised the food issue, Councillor Evans, but of course it extends beyond that to the winter warmth grants, and the Citizens Advice as our partners also have funds which will help people with their energy and potential issues of food poverty, fuel poverty, fuel poverty, and boiler breakdowns. This sort of thing is all accessible, working in partnership. The Together We Can, again, another partnership but run by the council. That group has never stood down since it was set up in the early days of the pandemic, and I wouldn't want to miss this opportunity, as I've taken it up at every other time, of paying tribute to the people who were involved in setting that up and to developing it over the past few months. And that is the best access for any of our residents who can't access support through the website. The web pages are quite comprehensive now, but the phone number for Together We Can remains actively manned during the week, and there are people ready to direct any resident who's in need through to support there.
Thank you, Nicola. Would you just like to say that phone number? Anybody listening who doesn't know it now?
Oh, this is one of those moments when you really hope it doesn't go out of your mind. Chairman, it's 0300 123 7052.
Thank you. Sorry to put you on the spot there. Any other questions for Councillor Green? No? Okay, well, we'll be seeing a little bit more of you a little later on, won't we? So if we move on to agenda item 8, which is a COVID-19 update. Now, members, you should have received a report sent earlier, end of last week, on the slides, the PowerPoint presentation. So I hope you've all had a chance to have a look there, because I would like to have these meetings as assume that you have read all the reports and papers, and to use the time more for asking questions of the officers. So if I can ask Jan Thorgood to start with this COVID-19 update, because I'm not 100% sure we've got Sam Crow with us, but if Jan, would you like to start off, please?
I think, yes, Sam is with us. What we were intending to do, if it is possible, Chairman, was to just run through the presentation very briefly with Sam Crow, followed by David Vitti, followed by Phil Hornsby. One of the issues for us at the moment is that things are moving so fast that there will be more updated information to give this evening from the position on Friday. So if it is possible, Chairman, if the officers could very briefly do an update for members, just so that members are cited on the position as of today, particularly for Sam, but I think David and Phil will also just want to pick out any new issues that have arisen since Friday, if that's permissible.
Yes. I mean, we know that the figures are changing daily, so as soon as you put it on paper, it's already out of date, isn't it? So I think Sam Crow, you're the first one. If Joe, can you share the screen with Have you
Absolutely, Chair. If you just bear with me for one moment, I will share the presentation slides. Please shout if in the next sort of 10 seconds they haven't appeared.
No, I can see them. Thank you, Joe.
Excellent. Thank you very much.
Would you like to start?
Thank you very much, Chair, and good evening, members. Good evening, committee. So, as Jan mentioned, I'll rattle through the first few slides, and I'll try to give you a much more up-to-date position than when these were put together, which only seems like a few days ago. So, if we can have the next slide, please, Joe. So, the current summary position as of last week was that the local cases that we've been particularly concerned about in BCP Council did appear to be declining from January the 6th onwards. But just to give you a kind of sense of the scale, we were still seeing perhaps 400 cases per day, which is a huge amount of cases. And if you look at the past 2 weeks, we've had more than a third of the entire number of COVID-19 cases in that 14-day period. So going back right to the start of the pandemic at the spring, BCP Council's had around 18,000 diagnosed COVID-19 cases, and more than 6,300 have happened in the past 14-day period for which we have data, which just brings it home just how serious this current peak has been. So I'm just going to update you with the current 7-day infection rate for BCP Council. As you can see, it was 881 cases per 100,000 between January the 3rd and the 9th. Today, it's down to 832 cases per 100,000. But we are very concerned by the continuing infection rate in the over 60s, which was 641 per 100,000. And on today's data, which covers the period January the 8th to the 14th, that figure is now 691 cases per 100,000. So an extremely concerning picture. And if you look at the reasons why that infection rate is so high in the over 60s, a significant proportion of those cases, perhaps a half to 2/3, are connected with current outbreaks in care homes. So still a really concerning picture, not only in terms of what's feeding through into bed occupancy in the hospitals, but in the wider system, and particularly in our care sector. The current southwest rate is improved somewhat. So the current position for the southwest is 375 cases per 100,000, and the figure for England now starting to come down quite quickly. So it's at 499 cases per 100,000. So it's moved quite quickly just in a few days. No real change in testing positivity. But there is good news on the growth. So as this slide says, we were looking at the growth in the cases starting to slow, and then we reached the kind of plateau a couple of days ago, and we've now started to enter the first period where we've seen negative growth. So when they compare the two 7-day periods, the most recent 7-day period, which is the 8th to the 14th of January, shows a reduction in the growth of cases of 2% compared with the previous 7-day period, and that's the first time we've seen that in BCP Council. The next slide, please. So this is just a reminder of proportionality, really, and scale. You can see right in the beginning of the pandemic, we didn't have access to widespread community testing, so it looked as if the outbreak in April was fairly insignificant, but we just simply weren't able to measure the true number of cases in the community. As we came into the period which resulted in the second lockdown, which was the late summer period and the early autumn period, you can see we were really concerned about this peak here, which led to all of the discussions about the need for tighter restrictions and indeed national measures. But you can see what we've experienced throughout mid-December onwards has really dwarfed what was going on before, and that just shows the seriousness of the situation. So this isn't a rate. What's shown on the left-hand axis here are actual diagnoses, and you can see that at some points we were seeing more than 600 people diagnosed with COVID-19 a day, which is a very high number for BCP Council. Next slide, please. This just shows the infection rate per 100,000 population. To some extent, this has lagged behind a little bit the data that I've just shared with you. But one of the points that I wanted to make to committee tonight is that you can see some neighbouring councils and their infection rates as they've changed over the last couple of weeks. If you look at Dorset, if you look at Southampton, and if you look at Hampshire, they all appeared to reach a peak a little bit earlier, perhaps a week earlier than the BCP council area. And what was concerning was that we were still seeing this growth in cases for perhaps a further 6 or 7 days in the BCP council area. That's what we've been monitoring really, really closely. And I'm pleased to say that tonight we are seeing sustained falls now, although it's not a steep fall. We're hoping that that trend will continue and begin to accelerate as the lockdown measures take effect. Then the next slide, please. So just some key public health actions, just to remind members, we've been working on our comms and engagement very hard to stress the urgency of the issue. It may sound strange under a national lockdown to do that, but I think we still see evidence when we are out and about in the community that some areas are still very, very busy. So we wanted to stress that and reinforce with the public the importance of the stay-at-home message. So only going out for essential reasons. The postcard has landed in the last day or two across every household in BCP Council, supported with some messaging developed by the Local Outbreak Engagement Board. We've been supporting the wider system to look at how we plan our capacity to cope with the surge in cases. So our EpiCell continues to adjust the model, and they're doing a lot of work currently on critical care capacity, which will be really important over the next 2 or 3 weeks. So it's important to realise that we probably won't get through the peak of the impact in hospitals until around about January the 24th. So what we're seeing in our hospitals at the moment is a result of infections that occurred perhaps a week to 10 days ago. And it always takes time for any reduction in our community cases to feed through into a reduction in pressure in hospitals. So the work of the EpiCell really crucial in supporting how we make sure that those forecasts are as accurate as they can be so that we know what capacity to bring on. We've been writing regularly with our adult social care directors to the care sector across both councils, advising them of the current position. And also we took the action a few weeks ago to ask them to consider stopping all non-essential visits. And we're publishing information much more regularly on the Public Health Dorset website and across both councils' social media channels. And in that, we're signposting people to the daily Public Health England updates, which are now much, much more comprehensive, certainly than they were in the summer. Today, BCP Council started its testing of frontline council employees, which is an absolutely huge effort to get that going, and a huge thanks from me to everyone who's been involved in standing that service up really quickly. So this is rapid testing. We have focused it on the council employees who are most likely to be working with vulnerable groups, most likely to be going into the community, where there may be a risk of particularly spreading asymptomatic cases of COVID-19. So those rapid tests are available at Poole Civic Centre, and we'll be looking to accelerate the delivery through the use of 2 buses that will be offering a mobile solution to employees not able to get to the Civic Centre site. And very shortly, we'll be extending that testing to people working in the community not covered by some of the other national offers. So that's anyone else in the community, particularly looking at sole traders, other groups that might not be covered by a large employer, to make sure that they could also access community testing. Next slide, please. So just a final slide on some of the key issues over the next few weeks. I think what we're seeing is that the virus appears to be more transmissible. We're seeing this in our care home outbreaks in our wards. We're continuing to remind people that it's more important than ever that we adhere to the public health measures, making sure that the communications around vaccination and rapid testing in particular is really clear, because neither of those interventions means that people should stop social distancing or practicing good public health measures. And making sure that we get infection rates in the community right down again. If they are still reasonably high when lockdown ends, we just risk firing the infection back up again. We saw that when we came out of lockdown too. It didn't take long before we were in a much more serious situation. We're doing a lot of work regionally on behavioural insights and developing content for different age groups, and try to sort of shift the emphasis on praising compliance with behaviour and not highlighting instances of poor behaviour so much, just in recognition that sometimes, particularly with some groups, you get a bit of a kickback when you're always focusing on negative behaviour. So trying to find ways of emphasising that by and large, most people have complied really, really well. So that message has been a strong message over the past week or so. And I've talked about the rollout of community testing. The important point to take away is that this is about finding additional asymptomatic cases. It is not about using rapid testing as a substitute for isolating if you're the contact of a positive case. So lots of communications this week to make sure that those messages are heard very clearly by the community and people taking advantage of testing. I think that's all from me.
Thank you, Sam. Did you want to take questions now or at the end? About this
happy to take members have questions.
That's fresh in their minds. I can see there's a hand gone up, but unfortunately I can't see whose hand it is.
Councillor Diana Butler, I believe.
Okay. Councillor Butler, have you got a question for Sam Crowe?
Yes, please. Sam, how many, do we know how many people who've actually tested positive for coronavirus have actually recovered from their illness? Is that data that's available?
Yes, I believe the CCG dashboard regularly shows people who've been in hospital who've recovered. So difficult to say from all those cases in the community, but certainly people who've been admitted to hospital. On the dashboard, you can find the sort of running total of people who've been in hospital and have been discharged as recovered. I don't have the figure to hand, but we can certainly supply that for your information after committee.
That would be really helpful. Thank you.
Thank you, Sam. I've seen two of the hands go up, Councillor Sandra Moore and Councillor Roberto Rocca, but I believe there was someone in front of them. So if they'd like to make themselves known and to ask Sam their question, please.
I've got Andy Jones first.
Thank you, Councillor Jones. Hi there, Sam. Just a quick question. Really encouraging to see the BIC open up today as a vaccination centre. And I think I'm right in saying that this can be the possibility or the capability of testing around 9,000 people there a week. I was just wondering whether it be possible at some stage, or whether it's even being considered to extend the opening hours of the BIC. So obviously we can vaccinate more people. Is that being looked at or considered? Although obviously I appreciate it's going to be pretty resource intensive to do that.
Yeah, thanks. I think it's a really good question, and I'm not in control of the delivery models. That's being led by the NHS. I think NHS colleagues would probably say that it's one of the most important factors is the workforce on hand to be able to staff the centre. I'd also make the point that it's not just about the mass vaccination sites, although it's great to see that opening today. The volume of vaccination being delivered by the primary care networks is really important as well. They've been doing a tremendous job rolling that out to the community. The third point to remember is that at the moment, they're going as fast as vaccine supply will allow. So we may well see changes to the planned delivery as the vaccine starts to flow much more freely. But certainly it's stepping up in scale and pace. But you also have to remember to do 2 doses and to cover that many people in the population is an absolutely mammoth task. So I think everyone's mindful of the impact on staffing resources to keep this effort going, day in, day out. It's going to be a real challenge over the next few weeks, but really good points.
Thank you.
Can I add to that, Sam, because I have put my name forward. There is a volunteer section that you can, and if anybody's interested, I could send them the details after the link to it. You can volunteer to be trained as a vaccinator. You can do other work there. You can marshal. There's all sorts of things, and I think it's put together with the St John's ambulance. So obviously it's going to take a little time to train people, but yeah, there's a vast number of willing volunteers out there who give up their time sort of free for this. So I just thought I'd mention that. Councillor Sandra Moore, I believe you have a question.
Yeah, thank you, Chair. Well, I did have a question about the BIC, but Andy got there before me. But perhaps I could make a comment about the Public Health England updates that have been going out on social media. And I just wanted to say that I've found them really helpful, and I've been sharing like mad. and people have clearly been picking them up and, you know, thinking it was good to get this sort of information. Social media is clearly the way forward. The only thing that didn't go down very well on social media was the postcard. That wasn't well received at all. People were complaining hugely about that. So, you know, by my calculations, you obviously hit the spot. It's called guilt, I think, and carry on doing it. Anyway, thank you.
Thank you. I'll make sure that I pass that on to the communications team. They've done an absolutely amazing job throughout the pandemic. So thank you very much.
Thank you. Councillor Roberto Rocca.
Thank you, Chair. I would like to ask just a clarification on the slide 2 about the current position. Reading the numbers, I think after the presentation was prepared, we had more cases that they came. I think we reached up to 649 in one day, if I'm not wrong.
That's correct.
So yeah, so it's still valid. The first bullet point that is a number of the cases began to decline from the 6th of January, or we are in a different case.
Yeah, it's a really good point. The daily case numbers move around quite a lot because some days they don't manage to quite add all of the test results in. So sometimes it goes down a bit and then you see a big step up again as additional cases come through. And for that reason, we look at the smoothed data, if you like, over the 7-day period. The infection rates are much more reliable. And you can see that because it's taken a long time for our 7-day rate to come down. And that's because of the variation, if you like, in those 7 days between the day-to-day cases. But you're absolutely right. We had 649. When I wrote these slides, I thought it was coming down in a nice, orderly fashion. But then we had another big peak when we had 649 in one day. Since then, it's been much lower. So I think yesterday's was 349 cases, but there'll be some variability on a day-to-day basis. That's a good point.
Thank you.
Thank you. Councillor LJ Evans, do you have another question?
Yes, thank you. I just wanted some clarification, Sam. So the total number of cases per 100,000 is just about starting to decline, but the over 60s rate is still increasing. Surely that's going to have the most effect on hospital admissions. So I was just curious as to your statement that the peak for the hospital might be in a week's time.
We draw our assumptions from the overall model. So what we use is we plot a curve based on the reproduction rate, not individual infection rates in individual age groups. So I think it probably depends on factors such as whether there are additional people admitted from the community, from those older age groups, that might increase the pressure on the hospitals. The original model that was drawn up a couple of weeks ago, I think was slightly underestimating the impact on the hospitals, and the Epicel changed their assumptions based on that. So the scenario that they're running at the moment forecasts that we're likely to continue to see that pressure on the hospitals until January 24th. We were a bit more optimistic a couple of weeks ago, but you're absolutely right. If that doesn't start to come down, and we continue to have a high infection rate in older ages, then obviously that feeds through into a higher risk of serious disease and a higher risk of hospitalisation. So Epicel look at this and review it on a regular basis, and if we feel that the observed pattern doesn't match the model, then they will rerun the model with changed assumptions. But it's a worrying situation.
Thank you. Councillor Nicola Green.
Thank you, Chairman. I'm sorry, Councillor Phillips, I hadn't seen your hand up. Would you prefer me to come back when all members have asked their questions? It was just a wrap up, really, if I may, to this part of your discussion.
Yes, is it a quick question, Councillor Phillips? Because obviously we've got some more.
Sorry, yes, it will be quick. Sam, you're saying about the over 60s and in care homes. what are the numbers of older people 60 in care homes and the 60s in their own homes? Because I was under the impression that those that are shielding are staying quite well. I haven't seen cases amongst where I'm sort of dealing and speaking to colleagues where it's breaking out with big problem. So what is the percentages of in care, not in care, of over 60s?
I think it's quite hard for me to give you exact figures tonight, Councillor Phillips, but you've got to remember the over 60s is quite a big group. So there'll be people that are well, they'll be living in the community, they'll be getting on with ordinary daily activities as much as the restrictions allow, but there'll also be some quite elderly people within that cohort. So it's a big age range. What we do know is that overall, in terms of the cases that are coming through community testing, around 13.5% of all of those positive cases are in people over the age of 60. And obviously that includes a big variety, doesn't it? Some people will be living independently, but other people will be in care homes. So when I did a rough calculation, what I was looking at was what's the expected number of cases for that age group overall for BCP Council. And in a 7-day period with our current infection rates, that's around 650 cases. And if you look at applying the 13.4% figure of cases that are connected with a care home across all of our cases, you get around 450 or so cases. So that's where you can sort of get a bit of a judgment that maybe 2/3 of those cases are connected with care settings overall.
Okay, thank you.
Councillor Dwayne Farr, is it a quick question? Because I think we need to wrap it up on this section because we've still got quite a bit to get through.
Yeah, it's a quick question. My question was, with what we're currently seeing there with the cases, is this the mutation of the virus, or is it the same strain as before? You know, is that something that's being noticed? Thank you.
Yeah, thank you. I mean, there's been a lot of discussion nationally of the so-called new variants. I guess I'd make the point that there are lots of variants of COVID-19, but the strain that seemed to be causing most concern was associated with patterns in Kent and parts of London and the southeast, where it looked as if it was more transmissible. It's been quite hard to tell locally exactly how much of the cases that we're testing are of that new variant strain, because they sample just a small number of the cases and genotype them. So genetic testing isn't available on the vast majority of community cases. But what they can tell is they look for a couple of genes that have dropped out from the strain of COVID, and they can run that on the big, what are called the lighthouse laboratories that do the vast majority of community testing. It doesn't definitely tell you that the new variant is present, but it's a proxy marker for the new variant. So our assumption is that the new variant is here and it is probably playing a role in transmission. But I would make the public health point that whether we have a new variant or not, it doesn't detract from the basic messages and the basic advice around infection prevention and control measures. And we mustn't see a weakening of that, regardless of which variant we're dealing with. It's all COVID-19. It all has the ability to be transmitted fairly easily. And we've got to continue to do all that we can to try to get those infection rates down.
Thank you.
Thank you, Sam. Councillor Green, did you want to just give a quick summary of this?
Thank you, Simon. Just briefly, there are two things going on here, which the first of which is that it looks as though we may have moved beyond the peak, but it might be better to cast that in terms of we've moved beyond this peak. We want that curve to continue to go down. And we're still, clearly, as you can tell, how quickly the case rates are moving. But I think both Councillor Evans and Councillor Rocco's questions delved into that, and there is a story behind the position that we're in now. And for me, the most significant one is that we have still a very, very long way to go. the point that Sam has made, that we have not seen the peak of hospital admissions, and very sadly we know, having followed the heat map, which I think this panel has seen before, of how increased cases move through the age groups, and sadly related in hospitalisations, and very sadly subsequently in deaths, is something that we always need to bear in mind. So very sadly, some of those cases which are already beginning to be identified now are the ones which will lead to further hospitalisations. So it is really important that the message goes out and continues to go out, that lockdown has some positive effects in terms of bringing those cases down, but it works when everybody does it. And those key messages, we might be rather irritated by hearing them again and again, but they are absolutely crucial. And I would ask for members' continued support. And I'm really grateful for the work that everybody does in passing on those messages, but we still have a very long way to go on this one. Thank you.
Thank you, Councillor Green. Joe, can we move on to slide 7 and onto the adult social care section of this? So.
Thank you, Joe. Yes, I have a few slides here to talk about the impact on operational adult social care of the current wave of the pandemic. I suppose first of all to say that we really do need to devote a good deal of our effort to preventing people from going into hospital at the moment, in order to help the hospitals manage with the demand. But the reality is that we're having to put most of our resources behind rapid hospital discharge. And there's an item later in this committee which will talk in more detail about the Home First approach. When I wrote this, I thought we were likely to see an increase in safeguarding and mental health demand during this latest wave. And in fact, that is the case. We are now seeing numbers going up for both Mental Health Act assessments and safeguarding concerns. Hardly surprising, because that's what happened during the first wave of the pandemic. And in particular, we're seeing some safeguarding concerns coming through the Together We Can programme. At the same time, we're seeing a little lowered demand for respite care. Again, not surprising, because people are looking to avoid going into care homes for short periods because of the risk of transmission of the virus. And similarly, I think people are worried about the risks of inviting domiciliary care workers into their homes. So where they can set aside some of their domiciliary care or delay receiving domiciliary care, some people are doing that. And equally, most of our care home placements at the moment are out of hospital rather than from the community. And I think the last thing I'd say about demand is that we're seeing increased pressure on family carers of people with a learning disability, because there are just less opportunities at the moment to provide a break for them from their care and responsibilities. I won't actually talk about the hospital discharge process, because I think we will come on to that later. So perhaps, Joe, I could ask you to go on to the next slide. A lot of these operational adjustments aren't new. We've been doing them since March, but actually we're stepping up. We're stepping up some of these measures now, including remote working, trying to avoid face-to-face contact between our field workers and our clients in our clients' homes, simply to avoid any risk of transmitting the virus. We're doing it where it's necessary and where we're worried that somebody may come to harm, but otherwise we're trying to use telephone and other means of contacting people remotely. A little bit worried about our sickness absence. It's perhaps not as dramatic as the health service is experiencing, but currently 25 of our staff are away from work with either COVID or suspected COVID. Although our overall sickness is down on the previous year, probably because there's less opportunity for people in the current restrictions to catch coughs and colds and flu. The staff testing that Sam talked about earlier has come online. That might lead to increased staff sickness. Some of our staff who are perhaps asymptomatic are now found to be carrying the virus and needing to self-isolate. We've also looked at alternative delivery methods for some services that just can't carry on at the moment in a way that's safe. So, for example, we're providing alternative daytime opportunities because our day centres are closed, and we're supporting carers to, for example, form online groups where they can use teleconferencing to support each other in place of face-to-face carers groups. Our in-house care services are operating broadly as normal, but our start service, which provides reablement, is mostly focusing its work now on hospital discharge, and our shared lives and supported living services, whilst not terribly affected by the pandemic, are devoting their attentions mostly to protecting our clients during the restrictions. And the Care Act flexibilities are some of those changes we are permitted to make under the Care Act. And principally, they have been the closure of day centres because it's simply not safe to allow people to attend because they can't socially isolate. But also some of our adaptations have slowed down. We're delaying adaptations to people's homes that are not absolutely necessary, simply because of the risk of inviting contractors into people's homes. And then, Joe, can I ask you to go on to the next slide? Thank you. I thought it was important to say that whilst we are in incident management mode and operating very rapidly to support our clients, and particularly hospital discharge, there's a lot of associated activity that's happening for us at the moment. Between March and August, people who left hospital didn't have to pay for their care. And since August, people leaving hospital generally are receiving up to 6 weeks of care without charge, so they can go through a period of recovery and reablement. And again, I think that'll be part of the presentation later in this meeting. But actually what that's done is that's changed very rapidly the way we have to pay our providers, bill our clients, in many cases not bill them, and we'll have to move people away from these newly implemented methodologies of discharge onto more normal care provision between now and March this year. So that's an awful lot of work for our finance teams and our back office teams who are having to do this often manually or to adjust the way they use our IT systems. And in the same way, we're having to now, in partnership with the CCG, reassess or assess people who may be eligible for continuing healthcare because those assessments were paused between March and August of last year. And then lastly, and I've covered some of these, but we're very alert to risks over the next few weeks. Staff absence I've talked about, and pressure on carers. Rising safeguarding alerts are starting to emerge, but we're worrying too about the well-being and resilience of our staff who have worked very hard, doing very demanding and stressful jobs, often working very long hours, and they've done that for months now. So we are very alert to how our own staff are feeling and the pressures on them. And as Councillor Rampton noted earlier in this meeting, we know there will be financial consequences of having to make rapid placements in greater number than we usually would do, and often at higher cost. And then lastly, I talked about people who are perhaps putting off care because they're worried about domiciliary care workers coming into their home. Well, as the pandemic subsides, I think it's quite likely that we'll see a peak in demand for adult social care services as a lot of those people turn to us for help that they've been putting off. So thank you, Chair. Those are the slides that talk about the operational impact on adult social care.
David, any members got any questions for David? Oh, we're getting off lightly, David. Councillor Andy Jones, there's always one.
You know me, Jackie. Yeah, thank you. Just a quick question, David, on mental health services. How short are we on resources in terms of mental health services as a whole. And is it simply down to a funding issue, or is it down to recruiting staff in the various areas, or is it a combination of the two?
Well, I think I can probably only speak for adult social care. There are a couple of impacted us during the pandemic. It's been difficult for the hospitals to manage people who have needed assessment and treatment, and that's made it a lot busier for our AMPs who would go out and assess people who may need admission to hospital. And actually our AMPs, because they're very specialist and we only have a few of them, are quite a rare and precious resource. And so we are concerned that if too many of them become unwell, then we'll struggle to reach everybody who needs a Mental Health Act assessment. So I think probably in terms of the pandemic, it's not particularly a matter of funding, it's a matter of resources being stretched in a way they never have before. And also the fact that a lot of mental health work is very responsive to acute need as it happens, can't be delayed, and we do need the resources to be able to respond very quickly. And so we have looked at bringing in some additional locum staff to make sure that we're sufficiently resilient and nobody has to wait for a Mental Health Act assessment.
Okay, thank you.
Thank you. I can't see any more raised hands. So thank you, David. Thank you, Sam, for your report. And as I say, I think the committee wish to extend the thanks to your teams for all the hard work they're doing. It's been going on a long time now for them. So yes, our thoughts are with them. So I think we can then move on. Jan, have you got a comment to make?
I just wanted to say, Chair, whether you'd like to hear briefly from Phil Hornsby from the commissioning side of adult social care, who is, there are a couple of slides just around commissioning.
Yes, thank you. Yes, Phil, would you like to?
Thank you, Chair. Yes, I'll be brief. Sorry, I think Matt's just making sure my computer's working properly. Just a few things. Councillor Rampton mentioned the distribution of grant funding in her report, and just to add that the council also made a funding contribution before the infection control grant came into play, which was just over 4.4 million. So in total, we've supported the care sector with just under £16 million if you add the infection control grant to that sum. We've been providing advice and guidance to the care sector right from the start of the pandemic. That's including one-to-one telephone calls with providers, which is partly quality assurance to make sure they're following infection control measures, but also to see how they're coping, whether they've got large staff absences, and how they're managing the care of the people that are under their responsibility. And in the main, providers have welcomed those calls and found them really helpful. And we've also signposted them to helpful good practice, best practice from their colleagues within BCP area, but beyond that as well. And we've always been circulating the relevant government guidance and legislation that's come out over the pandemic period, so that they've got the latest information to hand. And then Sam briefly mentioned that there's a weekly briefing note goes out from the Director of Adult Social Services, so in other words, Jan, and the Director of Public Health, which is just a summary of the week's highlights, headlines, and just things to note for the sector. And we've had feedback from the sector. They even use that in their staff room so that staff can see that there's an interest being paid by the local authorities. We've just been working closely with the Local Resilience Forum around, we've just noticed over the last couple of weeks some staffing shortages starting to appear, particularly in care homes. So we've been working with the Local Resilience Forum to look at how we can help coordinate and bring together volunteers. That could be people who are just willing to give a couple of hours support around administration, but also things like kitchen assistants, cooks, care assistants, and in some cases if there are nurses available. And the Rotary Club are coordinating that on the behalf of the two councils and the CCG, of how we can give a single point of contact for providers so they can just ring up and say, I'm short of this staff resource. Is there anywhere that you know that can give us that support we need? And then the final point under the supported care providers, we've through adult social care, we've been coordinating the vaccination of care home staff through the hospital. So Royal Bournemouth Hospital has been running a vaccination centre, and we've been making sure that staff within care homes and beyond can get access to that vaccination, been filling up the slots that have become available, and that's been really successful and welcomed. Some of that's been overtaken now by the mass vaccination centre and the work that the primary care networks are doing in vaccinating both care home staff and residents. So what's the care market look like today? So it was mentioned about the number of suspensions where care homes are unable to take admissions because of COVID outbreaks. So this morning that was 78 providers, care home providers, which out of 158 care homes that we have across BCP. So as Councillor Rampton mentioned, almost half. We are constantly reviewing those suspensions, so as they come out of their isolation periods, as they get negative test results, then we review and lift any temporary suspension, working very closely with the CCG's infection control team, public health, and the providers themselves. We have noted a rising cost of care. It's for care home placements, it's circa 50% more than it was costing us a year ago for each placement. And a lot of that's around the additional staffing that the care homes are having to put in to help isolate residents who may need to be supported to stay in their own room whilst they go through the isolation period, and stop them moving around wondering if they're unable to comply with the guidance around infection control. And that's had an impact on the availability of care. So we've at times struggled to access particular types of care. So high-end dementia need for nursing, but also some domiciliary care in the community as the lateral flow tests have come into being, regular testing of domiciliary care staff that has identified asymptomatic staff who may feel well in themselves, but obviously there's a risk of them spreading infection, so they've needed to self-isolate. And then the government brought out a requirement that for people discharged from hospital or unable to stay in their care home who were COVID positive, that they needed to go into a designated setting. That is a care home that's got a specific area, in effect an isolation unit, a floor, a wing, a section of rooms that allows them to support people who are COVID positive in a way that protects other residents in the care setting. And we have one designated setting within BCP area, that's Coastal Lodge, Tricuro run care home, where there are 10 beds currently, and we're looking to see whether we should expand that capacity. And then of course there are the community hospitals, some of which are also supporting COVID positive residents. So for the sake of time, Chair, I'll stop there, and if anyone has any questions that I can answer.
Thank you. Thank you. Has anybody committee got a question for Phil there? Councillor Mark Robson. Can you put your question to Phil, please?
Yeah, just get the camera on. That all sounds really nice. Yeah, that all sounds really nice. What's just on the isolation unit, 10 beds currently. What is their capacity? Do you think? What are you sort of planning for there? Is that as a specialised unit?
Well, we started with 10 beds because there wasn't a huge amount of demand. So we 10 recently, we're sharing that resource with Dorset Council as well. But as the cases have risen in hospitals, we're looking to see whether we should double that capacity. And that would probably be enough because you do have to meet the requirements that the Care Quality Commission demand. And so you've got to go through an accreditation process. So today, Tricure have applied for that accreditation process to double the number of beds to 20. And we think that will probably be sufficient when we include the community hospital beds that we have access to as a system as well.
Okay, thanks.
Thank you. Have you got any more questions, Councillor Robson? Nope. Okay, Councillor Diana Bottler, I believe you have a question for Phil.
Yeah, Phil, you're talking about the we've got one place for people to go where to be isolated. Are there any more buildings that might be available that we can use? Is there anyone looking at where they are and what they could be used for?
That's a really good question, and we did go to the independent sector care market to ask that question some time ago, and Tricuro were the only ones that could comply with the CQC regulations or wanted to. So some care homes might have some vacancies, in fact a number of them have, but they're not able to meet the requirements to have a separate wing or a floor where they can effectively cohort the people that have an infection. This doesn't apply to people who acquire an infection within the care home that they normally live in, so they will be isolated within that care home. This is for people who can't return to if you like, a clean care home where there is no COVID or it's limited. It's people who are being mainly discharged from hospital that have acquired the infection either in hospital or just before they went in. So it's difficult for providers, and then there are issues around their insurance provider accepting that if they have COVID within the home that they bring in rather than having it acquired within the home, that might invalidate their insurance, and that's been raised with the government about what could be done to support the care sector in that matter.
Thank you. Diane, have you heard? No? Okay, lovely. Thanks, Phil, very much. So I think we can now move on to agenda item 9, the Home First programme, including an update on the Better Care Fund. Can I ask Elaine Stratman to introduce this item, please? Thank you.
Yes, thank you, Chair. Hello, everyone. I'm Elaine Stratman. I work in Adult Social Care Commissioning for BCP Council, and I'm one of the lead officers on reporting of the Better Care Fund. The report in your reports pack tonight to the committee on Home First and the Better Care Fund highlights how the Better Care Fund planning and reporting has been paused during the COVID-19 pandemic. It highlights the response to the new National Hospital Discharge Policy and the operating model, which commenced on the 19th of March 2020 in response to the pandemic. So the report aims to give a description of the model that's helping to facilitate hospital discharge when a patient no longer meets the criteria to reside in a hospital bed, which in turn will help free up hospital beds. It explains that out of hospital new and additional care would be fully funded by the government during the period, and that the service would operate from 8 AM to 8 PM, 7 days a week for hospital discharge, working in a multidisciplinary capacity. The report then goes on to describe how the hospital discharge policy and operating model changed on the 1st of September 2020, and how the Home First programme and the discharge to assess model has been implemented across Dorset to respond to the change in policy. A significant change to the policy from the 1st of September was that the government would fully fund any new and additional care and support for up to 6 weeks after discharge until the 31st of March 2021. It's important to note that a recent update from the National Better Care Fund team has highlighted that this approach will likely continue beyond the 31st of March, and that the funding of the discharge to assess approach will continue and sit within the Better Care Fund framework for the next financial year. Rather than go through the report in detail, the Chair and Vice Chair of the committee advised that it would be useful for the committee to understand how things are working on the ground and in practice. Therefore, I've asked my colleagues Betty Butlin and Helen Percy. So Betty is our operational lead for BCP Council on Home First, and Helen is from Dorset Healthcare, who's leading for Home First for Dorset Healthcare, to give you an update. Following their presentation, I'd like to hand over to Louise Bate from Healthwatch Dorset to give you more of an insight into the patient experience of Home First before we open the floor for questions. Thank you, Chair.
Thank you, Elaine. So is it Helen that's going first?
I think it's Betty going first, and then I'm following.
Okay, Betty, yes. Thank you.
Thank you, Chair. So Helen and I overview of how our teams are working and how we're delivering the service for hospitals through this very, very difficult time. So as a lot has already been discussed around the pressures on the hospital and the kind of pressures on staff working within the hospitals, I would also like to pass on my thanks to everybody who's working in the thick of it every single day. So as Elaine went into saying, and the report very clearly outlines, there was the discharge guidance in March and then the change in September and how we've been implementing them. So where we're at as of today is we have a model that is linked with the hospital, the spa, as we refer to it, which is a single point of access, and a one team. Those three areas take the patient who's ready for discharge, no longer needs to reside in hospital, right through their journey of their discharge, their recovery, and then making a judgment at the end where they need to go. So how we've done that within the Dorset area is we have our hospital staff to some degree still based within the hospital, albeit on lower numbers. For BCP particular, we've got around 50 staff that are working either within our acute hospitals and our community hospitals, and then linking in with the spa, working within the single point of access, and then within the one team. And if you look at the three of those, that kind of wraps the whole patient's journey until the point of their recovery, and then into whatever their long-term needs and plan might be. And in order to do that, we've broken the, because Dorset's very big geographically, we've broken it down into 5 cluster teams. And for BCP Council, we're cluster 1, which is Bournemouth and Christchurch, and then cluster 2 is Poole, and then there are 3 other clusters that involve our Dorset colleagues in our Dorset wider area. And within that, we have lead experts from across the whole system, health and social care, who are part of those clusters and who look at the discharge of everybody leaving hospital, and what their needs are and what they might need to enhance their journey. It's also about looking at any gaps, working with Phil and his teams in commissioning, looking at the workforce, looking at any mutual aid. It's also around how we map the coordination of assessment and how we get that right. And it's also looking at what data we need to collect, to learn from, and to show the progress and the outcomes for those individuals. And I guess one of the real priority things is around aligning people to services. That's probably one of our critical things. Phil has just touched on the number of homes that we have, and in the number of homes that are experiencing difficulties because of COVID. The situation now is not changing daily, it's changing hourly. It is that on, we meet in the morning and think we have a strategy and a plan, and then something will happen. And I guess I would just like to maybe pick up on some of the real critical things and then bring my colleague Helen in around, as Sam referred to, one of the critical things right now today is around critical care. It's around making sure that we have enough critical care capacity and enough critical care staff, being able to meet the people that are in critical care and require that service. That are either mechanically being ventilated or have other stuff going on with them. A lot of it's COVID related, there'll be a small percentage that isn't. And then within our whole model, not wanting to go into too much micro detail for you all, there are 4 pathways, I guess, within the model that all of the patients will go through. They'll go through one of the pathways. The first pathway, which is referred to in the guidance, is pathway 0. That is for people who can generally leave hospital and need no long-term support from either health or social care. And then you'll have pathway 1. Now that's the majority of people. They're 45% of the overall within the hospitals, and those people will need to have some kind of health and social care intervention to go back home. And then we have a very small percent of around 4% who will need a bed-based approach to managing their health and social care needs. And then we will have 1% of people that will need long-term and possibly bed-based support or 24-hour provision of some description. And they may be people that are end of life and very poorly. So we all work very closely to make sure that we align people to the right pathway. We align the services that we have to meet their needs as we've determined their needs to be with them and their families. I guess if you were wanting to know what is the real critical thing that we're struggling with is the level of demand coming in, and as Sam referred to the peak, we have not reached the peak yet. We are definitely building up to the peak. We know that pressure, we feel that, we've seen that this weekend, we saw it at the end of last week. Today we have absolutely seen it increase and increase from what it was yesterday and the day before. Sam said, you know, around about the 24th, we're predicting the peak to be the 24th to the 26th. And that will be very, very difficult for us to manage from now right through. The system is working so well together, never known the system to work in such tandem with one another. Everybody is helping, everybody is trying to do what they can do. And, you know, the staff that are in the thick of this every single day, they are just going above and beyond right across the whole system and supporting one another. This is a 7-day week service. It is a minimum 8 to 8. We don't finish, you know, staff do not finish at 8. And that is the reality on the ground. But collectively and together, I'm absolutely confident that we will get there, and we will give those people that we are helping and trying to support the best possible service that we're able to give them. And it's also about how we support our care providers, how we are making sure that we're respecting and understanding everybody's agenda, everybody's needs, all the pressures that they have, the staff sicknesses because of COVID, everything collectively just creates a very difficult, challenging situation that everybody is working so hard together at all levels, and you know, doing an amazing job. So I'm going to hand over to Helen, if that's okay, Chair, for her to come in, because we do this together.
Yeah, thank you, Betty. Yes, Helen.
Okay, thank you. So I'm Helen Percy. I'm Head of Community Services for Dorset Healthcare, and I want to back up what Betty said, that I've never known a time when health, social care, community, acute services have worked better together. It really feels as though something's just clicked, and despite how difficult things are, everybody is working as partners rather than working against each other, which maybe that has happened in the past, or in silos has happened in the past. And since March, when we've had to bring in discharge to assess and all of the new things that we've brought in, it's been a hugely steep learning curve for all of us. It's been massive change, and we still know that we've got quite a long way to go to really make it right. And you've probably heard of the Home First board and the Home First programme. The Home First programme was set up across all organisations to really look at, so we've made changes that were mandated according to what we were told to do. But actually what we want to do going forward is to have a really clear vision for how these services are run, take the best of what we've done so far, look at where things haven't gone quite so well, and really think about, okay, well, what does that look like in the future, opportunities to do that, and to actually make things work even better. That's probably all I want to say. I'm sure if we came back in 6 months' time, we'd be telling, and I really feel that this is an evolution, it's a journey that we're going along.
Thank you, Helen. Louise Bate, would you like to come here with your report that you've had as part of our report here? Louise?
Thank you, Chair. So I just wanted to talk about a little bit about the patient experience of all of this. Back in June, I think, I spoke to Nikki Mitchell at the council about gathering some insights from patients about about what it was like to go through the assess to discharge process. And we agreed to run some phone call interviews with people who'd gone through that system. So we spoke to 21 people in total. I think we probably tried to just around 35 people. Some of them didn't want to take part anymore, or perhaps had gone back into hospital, or for their own circumstances, they couldn't take part in the phone call interview. So we ended up running 21. And there was a mixture of patients and carers and family members that we spoke to. So we got a quite good balance of people through that system. And I think on the whole, people were incredibly understanding, actually, about the pressures that the system was under, the reasons why they'd had to, they'd sometimes felt rushed to get out of hospital, and perhaps some parts of the process hadn't worked as well as they could have. I think the main bits of learning from all of that were really around how much more information carers and family members needed, so that they felt involved in the process. How important it is to have a contact number, somebody you can reach to talk about it if you've got any questions after you've been discharged from hospital, because the process is was so fast, and sometimes people need a bit of time to think about what they need to ask. And so I think all of those bits of learning have gone into the Home First model, which is really positive. We were planning to do some more phone call interviews with people in October, and then, as you know, we went into another lockdown, and there have been some issues with having access to people to make those phone call interviews. But actually, just last week, I've been attending meetings, engagement and communication group meetings around Home First. And through that, we've been trying to get to a point where we could do some more phone call interviews with people. So talking to Anna Johnson at Dorset Healthcare last week, she's allocated a member of her team to organise some more phone call interviews for us to run. So in the next few weeks, we're planning to call another, hopefully have a similar number or more, at least 20 people that will ring, to see what the process is like for people now, and find out where there have been improvements and where there are aspects of it that still aren't quite working for people, where we could tweak the system to make it better. I hope that explains what we've been doing. If anybody has any questions.
Yes, thank you, Louise. Your work is sort of the vital feedback that that we need, isn't it, to design these systems as to what's good with them and what's not so good with them, and what just needs a bit of tweaking. So can I ask any of our panel members, have they got a Helen, Betty or Louise? Councillor Mark Robson. You're on mute, Mark.
Lovely, thanks. Yeah, I was initially a little bit concerned that out of the 800 odd patients, we've only managed to get hold of 21. However, what you were saying, Betty, sort of filled me with confidence that the Team 1 and the SPA development seems to have been progress forward. I know perhaps it's too early, and I know, Louise, you said you'd follow this up later on when it's been going for a few months. Does the team feel that that system now is giving the all-in-one approach, and that patients have got the information? And I appreciate it's difficult to place people.
Sorry, is it just me, or is Mark completely frozen? Did you hear what he was saying? Is it me?
It's frozen for me as well, Chair.
Frozen. Okay. Sorry, Mark. Perhaps we can come back to you, Mark. Has anybody else got any questions? Oh, sorry, Betty or Helen, did you want to answer the first part of his question?
Yeah. Shall I Shall I do that, Chair? Start and then Helen can come in.
Yeah, that's lovely. Thank you, Betty.
I think where I heard up to was where Councillor Robson was asking around, do we have the confidence really that the teams are now formed and that they're working in a kind of one approach? I think that's what I heard. I would say that now, because we introduced the bones of this back in March last year, I would say the teams are now definitely feeling that it's more embedded and that they're making headway, and they're making good headway. It was definitely a struggle initially because it came out overnight. One day, you know, the 18th of March, 17th of March, we were working one way, and then we had to completely change, you know, within 24, 48 hours to start to embed a new model and a new approach. So I would definitely say now the clusters are aligned. They're aligned to the acute hospitals. For BCP, the main acute hospitals are University Hospitals Dorset, RBH and Poole Hospital, and there are cluster 1 and cluster 2s. So I would, you know, we definitely have that. We have a multidisciplinary team approach, which is critical. And I'd be interested, Louise, and hope to hear some of the feedback that's what people are beginning to see. And I guess the concept now that we'll take forward after COVID, and when we all have time to breathe and reflect and strategically, you know, plan our way forward for the best service possible for everyone, will be around looking at, you know, how do we align services so that they're very much around recovery, not give people based on their long-term plans at the point of discharge. How do we make sure that we're just looking to get, you know, helping people to get out of hospital, and then really tangibly for everybody planning their long-term plan and recovery whenever they're out of hospital, and doing that in synergy, doing that together as one MDT approach for the whole of our population who need our help. And I would say that is definitely the model that everybody is signed up to. That is definitely what you ask our social workers, our occupational therapist staff, our assistant workers, our long-term teams. If you ask them what approach, they love the idea of people having their needs looked at when they're out of hospital, in a reactive way to get somebody out of hospital, and overprescribing, and sometimes overprescribing the wrong thing. So I think we've turned a curve, everybody as a system, our whole health system. So I'm confident now. If you'd have asked me this last April or May, I would have said probably not, because it felt very reactive, which was the right thing to do to the pandemic. But now I feel it's a model, and it's a model that we all own, and it's a model that we want to work and that we're all totally signed up to. I'll just ask, maybe Helen has something.
Yeah,
we've also got Councillor Mark Robson back, so I don't know whether you want to hear the second half of his question. But yes, Councillor Robson, are you back online now?
Yeah, I think so. Well, no, I think it's just the confidence that the new system was, and that we were just placing people in the right place and keeping that the communication going. I don't know how much quite I missed of your answer. Just as I just lost my Wi-Fi there as it dropped out. Actually, probably not need to go over too much of it again. I was really happy with your briefing. Actually, it was just confirmation on those points, really.
Yeah, perhaps Helen will just sort of summarise this bit.
Yeah, there's just a couple of things. So we are trying really hard to give everybody that's in hospital a leaflet that gives them information around. It's a national leaflet, but that we've adapted, give information around what to expect. That there is one nationally mandated point which I think is quite contentious, and that's during COVID, that people don't have a choice of where they go. So whilst we would always do what is the right thing for each person, the choice for somebody to stay in hospital while they get several options isn't there at the moment. So, and I think that's quite difficult for some people. And we're having to really make sure that our communication is solid, so that people realise that's not just a decision we're making. It's a national mandate at the moment during COVID that there isn't that choice, and I think that's quite hard and probably will be seen in patient feedback even now because it's still the same.
Lovely, perfect, thank you.
Thank you, Helen. Councillor Cheryl Johnson, did you have a question?
Thank you. It wasn't really a question. I just wanted to say it's very heartening from a professional point of view to hear that everything's working smoothly together. And I hope that this carries on after the pandemic and all the silos disappear. So thank you.
Thank you, Councillor Johnson. I have actually got a couple of questions if no one else has got a question. On the item 18, well, it was the summary of patients discharged during scheme 1. Do we know how many were discharged from hospital and readmitted perhaps within the week? Thank you, Betty.
Yeah, thank you, Chair. We will know that. We can show you because the hospitals gather readmission rates, and we would be able to get that for you, the actual detail. I don't have that with me right now, but we could get that for you if you'd like that.
Yes, it was just a query that if people were being discharged too quickly and and they were having to go back in again with the same thing, that was all. And
we are monitoring any incidents, any complaints, any issues, and what we are seeing is that there hasn't been an increase in incidents, etc., or patient deterioration since we've been doing this. And I think the key to this is wrapping our services around the needs of the person when they go home, because I think what we used to see is people discharged from hospital after probably quite a lengthy stay in hospital and then not really receiving any follow-up, and therefore people were going back in. Now the plan is that everybody that goes home has some follow-up within 48 hours. So the plan is that we sort them out without the person needing to go back into hospital unnecessarily.
That's good. That would be a positive, wouldn't it? Because we don't really want them having to go back sort of so soon after being discharged. And my other question was on item 39, and it was about the costs to the BCP, saying it's 650,000 per month, but it doesn't include staffing. Do we know what the other costs are? What that involves? Thank you, Betty.
I'm gathering that is around the additional staff cost that we've had to. Well, it'll certainly be an element of the addition of the cost, because we had to go from to a 7-day week service and then extended hours, and and increase our capacity in some areas around staff, because it involved operational staff, practitioners, as I've said, OT, social workers, those kind of roles, as well as a lot of Phil's teams around commissioning, brokers, and we introduced some additional roles as well that we learned from others around transfer care coordinator roles, different things like that. So some of the costs within that will certainly be around the staff and the extended hours and the 7-day service as well. Don't know if Phil or David want to add any more to that.
Phil, David, did you want? Oh, Phil Hornsby, please.
Yes, thanks, Chair. Yeah, It's difficult because some of it's been in overtime payments, particularly for the brokerage and the commissioning staff, and it's not reclaimable against the national funding. So we've had to absorb some of those costs ourselves as a council, but it's been the right thing to do to support our residents. So we've done that, and we will be able to identify those costs, but it's quite fragmented. And because we're not reporting it up as part of the national reporting, it's difficult to actually nail it in terms of pounds exactly, because it's just tied up in the staffing budgets for the unit.
Thank you, Phil. Has any members of the panel got any further questions? Okay. One of our recommendations was to request a report later in the year, autumn, possibly early winter, on the outcomes and the learning from the implementation of the full Home First approach across the Dorset integrated care system. So I think, members, I think we would look forward to that, because at the moment it seems to be a really good positive thing that's possibly come out of COVID that's about this. So if we could ask for that. So Joe, could we put that on our action plan, please?
Yes, certainly, Chairman. If there's or amendment from members of the committee, that will be added to our action plan and forward plan going forward.
Thank you. I can't see any objections there. So thank you, Betty, Helen and Louise. Moving on to agenda item 10. Joe.
Thank you, Chair, and sorry to interrupt between agenda items. I just wanted to let you know and the committee know that Sam Crow has actually emailed me with an answer to a previous question raised by Councillor Diana Butler on the number of hospital inpatients that have recovered from COVID-19 and been discharged. I can always forward this to committee members after the meeting, but the current tally is that 1,102 patients have recovered and been discharged from a total of 2,488 admissions. Of the admissions, 458 have died in hospital. Thank you, Chairman. I just wanted to let the committee know that we had an answer to that question.
Thank you, Joe, and thank you, Sam, for that very swift answer there. So moving on, agenda item 10 is the BCP suicide prevention plan. Can I just ask members that this is a very sensitive subject, so can I ask you to bear this in mind when asking your questions, please? So we've got 3 officers with this report: Joe O'Connell, Sophia Callaghan and Elaine Hurl. So can I ask one of them to introduce this plan for BCP? Thank you.
Chairman, apologies.
Oh, sorry, Councillor Nicola Green, did you want to introduce this?
Thank you, Chairman, and apologies for coming in. Elaine, I do think it was you. I might have spoken over, so I apologise for that. Chairman, just a couple of words of introduction to the topic, if I may, rather than to the paper itself, and to set the context. There is, of course, never an easy time to look at such a difficult and sensitive topic. But of course, the converse of that is that there's never an excuse for failing to do so. Suicide affects a small number of our residents, but the impact on those individuals and their families and other loved ones are uniquely devastating. This paper sets out the BCP approach in the wider context of the Pan Dorset strategy, and I'm very pleased it's coming to your panel tonight for the reason that something that members don't often get to do is to have an impact in the development of a strategy in advance. So this is very much a request to your panel for some overview. And one of the recommendations, of course, is that you may wish to consider is that you set up a small task and finish group coming out of this to help inform the Cabinet paper, which I will be taking forward in March. And I would just like to draw your attention to the wide partnership that's gone into the preparation of this. And I'd like to give my thanks to those partners from the health services, from Dorset Council, but also from within BCP. And I'd like, if I may, particularly to thank Councillor Bobby Dove for her laser focus on the equalities impact, which sits alongside this. So please, members, in your questions, I just say please don't treat this as a finished piece of work. This is a starting point and a request for you to do some more work on it. And I look forward very much to receiving that, so that when it goes forward to Cabinet, it can genuinely be an all-member piece of work. Thank you so much, Chairman.
Thank you to Councillor Green. Can we ask who was it? Elaine that was first?
Yes, Chair, it's Elaine Hurl here from CCJ.
Thank you, Elaine.
Thank you very much, and thank you again for the invite. Just to couch this in, yes, it is a sensitive issue, and yes, look after yourselves when we're talking about it. But the work that's gone into the BCP plan and the Pan Dorset plan is a really positive step forward, and there are some really positive things that will come out of the work. So I'm just going to give you a bit of background. So in 2016, if you can remember a time before the pandemic, there was 2016, and introduced in 2016 was the Crisis Care Concordat. Basically, that was an agreement that people in mental health crisis deserve and should get much better response from services in order to prevent crisis occurring. So as a Dorset partnership, we got together and everyone, all the kind of statutory and partner organisations signed up to the Concordat. And underneath the Crisis Concordat, there were two deliverables. One is the mental health acute care pathway, which is fully implemented, and it includes the retreat in Bournemouth and recovery beds and the connection service, which is the 24/7 crisis line. So that was one of the deliverables. In response to the National Suicide Prevention Strategy, which came online in around 2017. And the deliverable, we sat it underneath initially the Crisis Care Concordat, because all the partners were really signed up to this just being an extension of really decent crisis care. So last year, as a partnership of organisations, including Public Health, Dorset, the two councils, the ambulance service, Dorset Police, British Transport Police, lots of voluntary community social enterprise organisations, the Coroner's Office, the Fire Service. It's been a real partnership and a co-produced effort. Last year we were able actually to apply for funding. That funding led to us being able to develop the strategy and an implementation plan, and each of the work streams that we've got. You'll see it in the Pan Dorset plan. There are 6 work streams, all with a funding amount linked to it, and all pulled down from the national strategy as it pertains to the sort of Dorset and BCP area. So we've got a Pan Dorset plan that was produced with all those partners and any other people who were interested, and that includes some elected members also on that work. So we've had a really long time of partnership and close working that's we've managed to sustain. But last year 2 things happened. One is the funding that we've got in place, which has enabled the work streams to be taken forward in a much more kind of directive way. The other is a real-time surveillance information. So that real-time surveillance information is up to the day information about deaths by suicide and attempts at suicide. Up until last year in May, we relied on ONS data, which always trails a year at least behind. So we've only ever had national or predicted rates of suicide, but as of May, we've been able to actually say how many people have died by suicide across the whole of the county, and including the BCP area. And we also track the number of people who attempt suicide. That number is hugely different to the number of people who actually do die by suicide. As a result of those two things, partners have really gone away and developed their own suicide prevention plan, because, for example, the BCP plan, which largely Joe O'Connell and Sophia Callaghan have worked with other service leads to get to the point that is in the paper before you tonight, worked really hard to get that plan in place, but it's a response to the Pam Dorset plan, and it's BCP's approach to the delivery of the plan, which is, basically to reduce the number of people in BCP area who attempt suicide, and to reduce the number of people who actually do die through suicide. So I'm happy to take questions, and I think Sophia and Joe are still on the call, so hopefully between the three of us you should be able to fire away any particular questions you have.
Thank you, Elaine.
Thank you, Chair.
Got any members that want to ask any questions on the suicide prevention plan? Councillor Sandra Moore.
Yeah, thank you, Chair. I know I'm only subbing on this committee for my colleague, but I have to say I thought that this was an excellent report. It was very well written, and a great deal of work has clearly gone into it. This is clearly an emotive topic, but the report was written with great sensitivity, with an emphasis on taking a preventative approach, but with enough factual information to make an impact. It made an impact on me anyway. I was very pleased to see there's a list of proposed actions for various council departments and people, including councillors, who might, it's suggested, raise awareness and signpost resources to residents. I was also pleased to see that planning is involved to look at including suicide prevention measures in future designs for public buildings. And I wonder whether this could be extended to include looking to implement suicide prevention measures in some existing buildings and existing sites where there's a need, as well as future designs. And I wondered if perhaps this could be considered as well. Otherwise, I'm really pleased to be able to support the recommendations, and a big well done to the authors of this report. Thank you, Chair.
Thank you, Sandra. I think if we mind to have a task and finish group, your suggestion there on planning on existing buildings and sites could be one of the things that they look at. So thank you, Sandra.
Yeah.
Councillor Lawrence Fear.
Chair, I'm just going to speak on this item as the BCP champion for mental health. There's just a couple of points I wanted to pick up on this. First of all, I think it's a great starting point. I think it's a great paper. I think everyone involved should be very happy with the work that's gone in, and looking forward to more to come. I just want to pull up a couple of points through the report. The point 2.2, setting out the points going forward, I think embodies not only what BCP wants to do, but hopefully further afield across the county working together. So I think that's they are really excellent points, and how we're going to encompass different groups as well into this. And having those points there are a good marker, but also the evidence that we see in the report as well backs up. So 7.1, for example, where we have 77% of people who do die through suicide aren't actually involved through any programs. So there's 77% of these people who haven't been able to actually access any help or not had any help. And by starting off with this paper, we're going to be able to do tremendous work and being able to reach these people before a certain time. So I'd really just like to commend this paper and say well done. And I hope this ONS board will push this forward with gusto and look forward to the next step. Thank you, Chair.
Thank you, Councillor Fear. Elaine, did you have any comments on what's been said so far?
It's really, the credit needs to go to all the BCP officers for their time and commitment to the partnership work. It's really important that people talk about suicide. It's really important that people talk about it appropriately. And it's just a very good time to be doing this work, especially with the development of the real-time surveillance information, because over the next few months, we should really be able to see whether people who have ended their lives have been open and known to services. At the minute, that's estimated and based on national trends, but that may not be pertinent to the Bournemouth area as it stands. So that real-time information will enable us to have a really targeted approach to trends and themes, both in people who do end up dying by suicide, but also people who reach that point where they think that suicide or self-harm is their only real solution to their issues. So it's a really good time to be developing this work, and many thanks for the appreciation of the report.
Thank you, Elaine. Councillor Andy Jones, I believe you have a question. Andy, are you on mute?
Apologies. Yeah, sorry, Chair. I was just wondering what support there is available more widely to support individuals who have been affected by suicide bereavement. I know a couple of people that have been or has experienced this over the last couple of years or so, and the support mechanisms in place seem to be pretty limited. So just wondered perhaps if we could talk a little bit more about that, and maybe can we incorporate it in the plan, or is it in the plan and I've missed it?
So it's one of the key things that the co-production group in the Pan Dorset plan has kind of raised. As a response, we've developed a project called Open Door. I can send out the details. Open Door is available as it's a one door offer that gives access to several different organisations, such as Cruise, such as Mosaic. Anyone can call it who's either experienced loss through suicide and also has experienced loss through COVID. So I was going to mention it actually because earlier one of your speakers talked about the bereavement offer that's generic through the council helpline. This is a very specific service that if someone's experienced a complicated loss either through suicide or COVID loss, then they can approach that Open Door service. It's funded, it's a trial to see how it works. It's open and up and running now, and it means that anyone can call it and get really good advice, support. They'll get a really good kind of initial conversation to make sure that there's a warm transfer in terms of, so for example, the call will go into the Open Door and there'll be a warm transfer to Cruise or to Dorset Mind or to other organisations involved in bereavement support, depending on that person's needs. So it will mean that the person gets to the right place it's there and it's working across Dorset, so including BCP. I'll make sure that the details go out. And sorry, just to mention, Help is at Hand. It's you can download it from Public Health's website. It's called Help is at Hand. It's anyone can download it. You can also order Z cards and booklets that describe and provide lots of information about helplines and advice lines, and lots of info about coroner processes and undertakers, and it's a really comprehensive guide for anyone who's got loss or advising people who may have experienced a loss.
Thank you, Elaine.
Thank you, Elaine. Councillor Mark Robson.
Hi, thanks, Chairman. Yeah, Elaine, just picking up on, just from my understanding really, what surveillance data is, trying to pick up on this 77% that we don't know about. Is that surveillance data, is that tracking, you know, failing companies, divorces, hitting that middle-aged man territory who are probably not going to come forward for help because they feel they can deal with it, and then obviously they realise they can't, so they take the stage further? Is that how we're going to pick up on this 77%? What's the
so just ahead of today, I did actually look at all the deaths across the Dorset area. There's a pretty good sense of there's mental health in the picture, there's substance misuse, there's relationship breakdowns, and there's quite a lot of people unknown. Now, whether the Dorset area actually is the same as that 77%, I don't think it is, just from the small number that I've looked at. By the end of April this year, we'll have a whole year's data to look at, and we'll be able to kind of give a good description of the demographic information. And the really, really important thing about the real-time information is that we will be able to adapt our work streams, our plans. We'll be able to target things. And just one example is that already from the data, we can see that men in their 40s, 43, 44, are most at risk currently across Dorset and BCP. And Dorset Mind, for example, have already started to work with a group of men who've got lived experience with a view to targeting work at getting men talking in places that men tend to visit, like barbers and sports clubs and football grounds, or maybe not, that's a bit too stereotypical, but you get the sense that we can then actually use information to target resource and media and training. So it's a good time.
Yeah, no, I don't think you have to be stereotypical. I think you have to be here. These are the people we need to be hitting or finding out, and if that's what it takes, I think, you know, we are different in species to a certain degree. So you've got to go with where we're going to find them. Yeah, I absolutely agree. Yeah, good. Thank you.
Thank you. Councillor LJ Evans.
Thank you, Chair. Yes, this kind of follows on from Councillor Robson's question on the hard to reach. Specifically, I was thinking about our people from BAME communities and perhaps those who have English as a second language. But I very much take Mark's point about the men who historically tend to engage less with mental health services.
So real-time information that I looked at, there were 2 individuals who were not white and British. It's a relatively small number, but absolutely we've got to make sure that we reach as many people in as many ways as possible, and that's part of our approach. So, but really helpful to have the comment. Thank you.
Thank you. Councillor Diana Bottler.
Sorry. Thank you, Chair. It's really going on from that about reaching people who you can't usually reach. Will the plan be including making posters or stickers to put in different public places for people, so that if they don't want to be obvious that they need help, they might read a telephone number or the name of an organisation in private. So, you know, places, you know, I've seen stickers in public toilets, you know, about abuse, things like that. Would that be looked at?
Councillor Butler, it's a really brilliant idea, and it's I probably will feed that back to the working group. We have a note of caution in that advertising local sites is not such a good thing. Talking about suicide is absolutely a brilliant thing, and it can prevent death, but advertising places by sticking posters up, and the only reason I raise that is because at one of the cliff tops around the Bridport area, people wanted to put posters up, and it was almost like an advert. So we walk a fine line between giving information that people can, you know, take away and actually go, that could really help me now, and so but really would feature that in the conversation. So thank you.
Sorry, it wasn't. I wasn't talking about specific sites like that. It would be places that people go to, like libraries, GP surgeries, dentists, things like that.
Yeah, no, that's brilliant. Thank you.
Okay, thank you.
Thank you. Have we got any more questions? No. Can we then think about whether we want to commission a task and finish group? Because if we do, it would just be one meeting of perhaps 3 to 4 members, but we need to demonstrate that we're going to add value to this report. So can I have a show of hands if you think that we should have this task and finish, and if anybody would like to be involved in it?
Jackie, I would put my hand up, but it probably will be in the daytime, won't it? The meetings or the meeting?
Well, we would have to have one of our council officers with us, so it would possibly be, yes. But as I say, because the officers' time's so precious at the moment, they're so busy and working long hours, we need to show that actually what we would be discussing would add to this report. But
No, so I'm out. Sorry, Jackie, if it's daytime. Sorry.
Okay, Joe, I think you've got your hand up.
Thank you, Chair. Yeah, it's absolutely to echo what you've just said about, you know, especially at this time where time is short and, you know, pressures are high. Best practice would indicate that the work of a task and finish group should have its aims very clear, and they should clearly add value. So if members are minded to commission a task and finish group, they should be aware that it would be, if the key officers involved feel appropriate, one meeting, very short, sharp, with clear aims and outcomes, and to be member led. So if members sort of recall the adult social care charging strategy working group that we had last year, once the work was completed, the sort of lead member fed back to the relevant committee. In this case, that will be Cabinet on the 10th of March. So it was really just to sort of outline the governance arrangements of the task and finish group if members are minded, and really to, at this moment in time, outline the key aims and how value will be added. Thank you, Chair.
Thank you, Joe. I feel from my point of view that Councillor Moore's recommendation about adding the existing buildings and sites to it, I think that's quite an easy thing to add to this report. That it does mention improving the bereavement support, so I'm not sure if we've got anything else to add that we could do with a task and finish. Councillor Evans.
Yes, just to reiterate, I think it's a very good report, and I'm not sure that we can really add anything extra to it, so perhaps not necessary to have a task and finish group.
Yes, I mean that's how I feel, and unless any of the members disagree, no, we won't go with recommendation number 2. I don't think it's such a comprehensive report. I don't think that we need to go with that. We do have another recommendation, and this would be possibly to go on our forward plan, Joe, is to receive a progress report on the plan for 2022. I think we've got to give it a chance to sort of bed in and that. So if the panel agree to put it on our forward plan for next year. Yeah. Okay, lovely. Thank you very much, Elaine.
Pleasure. Thank you.
Okay. Moving on to agenda item 11, which is our forward plan. Now, those sharp-eyed members would have noticed we've changed it somewhat due to officer time being taken up with something called COVID going on. So we've got our next meeting on the 8th of March, where we've got, it's like a regular item, this, a COVID update. So I think that sort of really speaks for itself. And then we've got a strategic outline case, which is to receive an informative update from the Transformation Director of the University Hospital Dorset NHS Foundation Trust New Hospitals Programme and what it means for Dorset. So any questions on that? No. Okay. And then the third item we've put down.
Oh, Chair, sorry, we've got Councillor Butler.
Sorry, I'll come in when you've finished your other point. Sorry.
Thank you, Diana. And the third one was a Health Watch update from Louise Bate. And one of the suggestions I sent across, but it doesn't have to be that, is that Louise will give us a brief summary of the projects they've been working on the 2021 year, and then the future projects that they'll be working on from April this year. So, Councillor Diana Butler.
Yeah, at our last meeting in November, Councillor Wilson and I both asked that the homeless and rough sleeping issue could be put onto the forward plan for March, because we've got to talk about this before the March Cabinet. And it hasn't been included. It's way down on the list at the moment with no date.
Thank you, Diana. Joe.
Thank you, Chair. If you're happy for me to respond to that, and I'm happy for any other officer to contribute. Firstly, the Council's homelessness strategy has been pushed back to the April Cabinet meeting. Therefore, there is now a slightly larger window of opportunity for scrutiny to be arranged on this matter. As an update, the initial conversations have been had following the information seminar that took place on the 7th of January, and these conversations are ongoing between senior officers. We will be liaising with the relevant chairs and vice chairs in the coming week to establish a suitable approach going forward. The wider issue of health provision for people who are homeless can certainly stay on the forward plan if it is a subject that the committee wish to explore further at a later date when it is appropriate. But specifically on the homelessness strategy, we are this week hoping to resolve and find an approach going forward to scrutinise it. Thank you.
Thank you, Joe. That sounds like it's a conversation to have further this week, because the part that we will be scrutinising is the actual health services that are available to the homeless and the rough sleepers. So, Diana, did you want to add anything to that?
Well, I think the suggestion was to fit in with the public consultation that's gone out this month, and the fact that we only meet every 2 months. So if the April Cabinet, that would miss our next meeting after March, wouldn't it? If we wanted to add anything to it, you know, to look at what had come out of the consultation.
Jan, do you have something to add to this?
Yes, I suppose the dilemma is at the moment that as Joe said, the plan would be that the chairs of the board and the two committees would meet and agree. how scrutiny can be done prior to April in the most efficient way. Otherwise, there is a risk that colleagues in our housing services will be asked to go to serial meetings, which just at the moment isn't possible in terms of the COVID response. So the commitment is that there will be scrutiny, which would enable members to scrutinise the strategy before, but that needs to be done in the most streamlined way at the moment. So if it's acceptable to committee, I think the chair would take on to agree with colleague chairs the best way to conduct scrutiny in the unique period that we're in terms of the not only of being in a pandemic, but actually probably being at a point, as we've described earlier in the committee, which is probably the most demanding part of the pandemic to date.
Are you happy with that, Diana? It's just, I think it's not something that will drop off our plan, because we can look at it further down in the year to sort of see how the strategy is working, for example, and to gather what health services we do have that we offer the homeless and the rough sleepers. Have I got any other questions for any other panel members? No? Oh, well, I shall declare this meeting closed then. So thank you very much for all the officers and the guests that we had, and to all our committee members. Thank you very much and good night.
Thanks, officers, and thanks, Chair. Bye.